the anterior wall of the rectus sheath, posterior wall of the rectus sheath, the rectus abdominis muscle. There are tendinous intersections at the level of defined process, at the level of umbilicus, and in between you can get, and you can get more than that. It might be 4 or like that. So the anterior, in the anterior wall, you will get the rectus, tendinous intersection, because the anterior wall remains attached with the rectus muscle firmly with the help of those tendinous intersection. Next, you have to identify the rectus muscle. Then you have to identify the anastomosis between superior and inferior epigastric artery. At least you have to search for inferior epigastric artery. Generally, the anastomosis takes place at the level of umbilicus, superior epigastric artery, and generally we can get it in front of the posterior wall of the rectus sheath. Okay, or even within the muscle mass of the rectus abdominis muscle, and rarely you can find behind also. So there is superior and inferior epigastric artery. Inferior epigastric artery is a branch that try to ask yourself, in inferior epigastric artery, it is coming from where? It is a branch from the external iliac. We know there is bifurcation of the abdominal aorta. Okay. Aorta, arch of aorta, then descending thoracic aorta, then we are getting the abdominal aorta, which bifurcates into two major branches, the common iliac, which again divides into external and internal iliac. So from the external iliac, we can get this inferior epigastric artery. So in the same way, you can ask yourself, from where I can get the superior epigastric artery. Superior epigastric artery, madam, superior epigastric artery. Madam will tell you about the origin of superior epigastric artery. Tell me. It is already done. Superior epigastric. What is the origin of superior epigastric artery? Iliac artery. She is saying iliac artery. Do you agree? Superior epigastric artery is coming from iliac artery. Do you have any iliac artery in the body? We have got common iliac, external iliac, internal iliac. Still we don't have iliac artery. And that too, superior epigastric artery, it is coming from, can anybody tell me, superior epigastric artery is a branch from which artery? Internal? Yes. Internal thoracic artery ultimately divides into superior epigastric artery and musculophrenic. Okay. তো ওখানে গল্প করছো কেন? এদিকটা মনটা দাও। হ্যাঁ, ঠিক আছে, ঠিক আছে। অ্যাপ্রনটা পড়ো, অ্যাপ্রনটা পরে বডিতে এসো, মানে ক্যাডাভারে এসো। So superior epigastric artery, inferior epigastric artery, we have to identify here at least the inferior epigastric artery. So rectus sheath, you should ask yourself what is the how the rectus sheath is formed. The anterior wall, posterior wall. We know there are three fat muscles: external oblique, internal oblique, transversus abdominis, and also we get the behind the transversus abdominis, we are getting fascia transversalis. Okay. So I am not going into the detail, just identify here. Okay, because disposition of horizontal disposition of rectus sheath at different level of the abdomen is a theoretical one. So at least we have to identify the anterior wall, posterior wall, rectus muscles, and the superior and inferior epigastric artery. And sometimes we can get pyramidalis muscle. Okay. Next is the inguinal region. In the inguinal region, where is the which one is the inguinal region? The below the umbilicus, we can get an area of the abdomen, that's the lower abdomen. If we join these two anterior iliac spine, and if we go below that area, there we can get the disposition of or the formation of the inguinal region, and we can get in the inguinal region we can get one canal, that is inguinal canal. So the inguinal canal, it has got anterior wall, posterior wall. Okay, we have got roof, floor, and it is extent. Extent is from the superficial inguinal ring to the deep inguinal ring. So it is present where it is present. It is present in the lower anterior abdominal wall. So there we can get from anterior to posterior. We get the external oblique aponeurosis. Then we can get the muscle, and then that muscle becomes aponeurotic when we approach towards the midline. Okay, so medially. So medially we can get the aponeurosis. On the lateral part we are getting the fleshima. Okay, the external oblique aponeurosis. And when first we are removing the skin, we can see there is just below the skin there is superficial fascia that is divided into two layers in the inguinal region, that is superficial fatty layer of camper and deep layer of scarpa, that is the membranous layer of scarpa. Okay, so that we can find. Okay, then if we remove that superficial fascia, then we can get the external oblique muscle, and here we can get that superficial inguinal ring which is present just above the pubic crest. Okay, pubic crest means this is very. So here we can get a inguinal, the superficial inguinal ring that is within the superficial, that is the external oblique aponeurosis muscle. So if we remove the external oblique aponeurosis from the midline, if we reflect it laterally, then we can get part of the inguinal canal, and also we can get the internal oblique and transversus abdominis muscle. Okay, medially they get fused and form a conjoined tendon. Okay, and we can see the inguinal canal and a part of the inguinal canal where we can get spermatic cord in case of male, and in case of female we can get round ligament of uterus. So we have to search for that spermatic cord. Okay, and also we can get one ilioinguinal nerve, which we can it pierces the internal oblique and appears. It does not passes through the deep ring. It joins with the spermatic cord and ultimately leaps through the superficial inguinal ring. Okay. Now, if we cut the internal oblique and transversus abdominis and we reflect, then we can get the deep ring that is present within the fascia transversalis. Okay. What is the position? It is half inch above the mid-inguinal point. That means joining the anterior superior iliac spine and the symphysis pubis. And if we go half inch above it, we can reach the deep ring, deep inguinal ring. It is present within the, so we have to search for the fascia transversalis where we can get the deep ring. And guide is, we can get inferior epigastric artery medially. Lateral to the inferior epigastric artery, we can get the deep ring, that is the guide. Okay. So this is from superficial to deep ring to superficial ring. This oblique canal moves within the inguinal region, obliquely placed. Muscular apparative canal, that is called inguinal canal, which causes the spermatic cord. What are the contents of the spermatic cord? You have to ask yourself, what is the content? What are the structures? The main bulk is formed by pampiniform plexus. That means the testicular veins. The testicular veins, actually, there are so many veins we can get within the spermatic cord. At the root of the scrotum, we can fill the spermatic cord, and what the most voluminous content is the pampiniform plexus or the testicular veins. There are so many testicular veins, they join and ultimately forms, we get the 4 testicular vein at the level of superficial inguinal ring. Then it joins and ultimately we can get 2 testicular veins, pampiniform veins, pampiniform plexus, 2 veins we can get at the level of deep ring. And when it crosses the deep ring, and it is coming from testis and ultimately it is going towards the inferior vena cava. And when it is crossing the deep ring, they 2 veins joins to form 1 testicular vein. On right side, it drains into the right testicular vein drains into, tell me, yes, inferior vena cava. Okay, on the left side, it drains into, the left testicular vein drains into left renal vein, where we can see them at the posterior abdominal wall. Okay, in the posterior abdominal wall, we can see the fate of these gonadal veins. Okay, and gonadal veins in female also, that is the ovarian vein, testicular vein in female, ovarian vein we can get, but the fate is same, that is on the right side, inferior vena cava, on the left side, that is the left renal vein. Apart from that, we can get vas deferens and round ligament of uterus in case of female. Okay, vas deferens. Any other structure? testicular artery. Any other structure? Abnormal structures we can find. That is the spleen. Very good. We can get the spleen also. Okay, or suprarenal gland, so and so. So, inguinal region we have to identify these structures. That is, the anterior wall is mainly formed by the external oblique muscle. Okay, anterior wall, and anterolateral it is reinforced by internal oblique muscle. Posterior wall is mainly formed by the fascia transversalis, and medially it is reinforced by the conjoint tendon. So, we have to identify the external oblique, we have to identify the superficial ring, we have to identify the deep ring, we have to identify the spermatic cord, okay, and fascia transversalis. And in rectus sheath, there is one linea semi-lunaris and linea semicircularis, because in the inguinal region the posterior wall is deficient. Okay, from the level of we have to make a level, that is from umbilicus to the symphysis pubis. From we can make the middle of it, from below that level the posterior wall is deficient. It is formed only by the fascia transversalis, and we can find a linea semicircularis. Okay, and semilunaris means that is the rectus sheath. Okay, the rectus muscle has got the lateral boundary, that is the linea semilunaris. So these are the points. Then in the posterior abdominal wall, what we have to find? Several the nerves of lumbar plexus, subcostal nerve, subcostal vessels and nerve, Iliohypogastric, Ilioinguinal. They are actually Ilioinguinal is collateral branch of Iliohypogastric. Okay, L1. Iliohypogastric, Ilioinguinal, then we can get lateral femoral cutaneous. Okay, lateral femoral cutaneous. Actually the psoas major muscle is, and we have to first identify the muscles, that is the psoas major muscle. Lateral to that, quadratus lumborum. Lateral to that is transversus abdominis. And from the lateral border of the psoas major, we can get these nerves. The nerve, that is the subcostal vessels, and nerve just below the 12th rib, we can get subcostal vessels, vein artery nerve, 12th thoracic nerve. And the first lumbar nerve is continued, the ventral rami is continued as iliohypogastric, and its twig is called ilioinguinal, iliohypogastric and ilioinguinal, L1. From the lateral, then below that ilioinguinal, we can get lateral femoral cutaneous nerve. Root value is L2, L3. Okay, from L2, all the ventral branches of ventral rami. The ventral branches are important. Ventral rami are important. Dorsal, we are not concerned with the dorsal rami. Again, ventral rami again divides into ventral branch and dorsal branch. So, dorsal branch of ventral rami of L2 and L3 joins to form the lateral femoral cutaneous. We can find it over the key point is iliacus muscle. We can find over the iliacus muscle that lateral femoral cutaneous, and just below the anterior superior iliac spine, we can see, and ultimately what is the destination? That is the lateral part of the thigh, the cutaneous. It gives a cutaneous supply to the lateral part of the thigh. So, lateral femoral cutaneous. Then, femoral. In between psoas major, where we have to find in between psoas major and iliacus, iliopsoas groove. Iliopsoas is we call it as a twin muscle, okay, because the insertion point is where that is the lesser trochanter of the femur. So, in between iliacus and psoas major, we can get femoral nerve. Dorsal branches of ventral rami of L2, L3 and L4 joins to form this nerve. It's a thick nerve. When it crosses the inguinal ligament, it is very much apparent in the femoral triangle, where it divides into anterior and posterior branches. If you can remember, the anterior branch has got two cutaneous, one muscular, and the posterior branch is basically muscular, four muscular for the quadriceps, and one is cutaneous, that is the longest cutaneous nerve of the body, that is the saphenous nerve. Saphenous means very easily seen, which can be easily seen. So, that is the saphenous nerve. So, there is a femoral nerve. Just in front of the psoas major, we have to identify genitofemoral nerve. Dekho, just in front of the psoas, we can find the genitofemoral nerve. So, that genitofemoral nerve, the root value is L1 and L2. L1 and L2, genitofemoral. Rather, femorogenital, L1 and L2. Femoral region and genital region it supplies. Okay, that is the genitofemoral nerve. Then we can get, that is coming out, it is piercing the muscle and it is apparent in the anterior aspect of the psoas major. From the medial bone of the psoas major, we can get the obturator nerve. At least you have to identify the obturator nerve. You have to lift the medial border or medial side of the psoas major. In the lower part, you can see obturator nerve, which supplies the adductor compartment. This is abduction. This is adduction. Abduction, adduction. So, adductors, there are adductor brevis, adductor longus, adductor magnus. So, those compartment is supplied by this obturator nerve. It has again anterior and posterior division, okay, which is the anterior division is present in front of the adductor brevis, and posterior division is present behind the adductor brevis. And ultimately, it supplies even the medial side of the thigh and also the knee joint. And we know the obturator nerve, it is present on the lateral wall of the pelvis. In the lateral wall of the pelvis, we have seen the pelvic, in the pelvis, there is one artery, very important artery, that is the internal iliac artery. Okay. From anterior division, posterior division, we are getting so many branches. From the anterior division, we are getting the obturator nerve, a obturator artery. So, obturator nerve, artery, vein, they are passing through the lateral wall of the pelvis. This is the lateral wall of the pelvis, and the lateral wall of the pelvis is nothing but this forms the ovarian fossa. Okay. So ovary is just medial to it. So if there is any inflammation of the ovary or any pathology, any malignancy, anything can affect this obturator nerve. So the obturator, so if it irritates the obturator nerve, we can get pain along the medial side of the thigh, and the pain may radiate to the hip joint and knee joint, because both the joints are being supplied by the twigs from the obturator nerve. Okay. Then we have to identify more medially, that is the oil structure. Obturator nerve, I, iliolumbar artery, L, lumbosacral trunk, and S is the sympathetic stain. So we have to identify those structures. And apart from others, we have to identify the inferior vena cava. We have to identify the abdominal aorta. We have to identify the ventral branches of the abdominal aorta. That is the first one is the celiac trunk, superior mesenteric artery, and the inferior mesenteric artery. From the T12 level, we can get the celiac trunk within the lesser omentum. Okay. We can get the celiac trunk, which is the artery of the foregut. We can get the superior mesenteric artery at the level of L1. Okay, this is the artery of the midgut, and inferior mesenteric artery we can identify. Okay, so superior, the celiac trunk, we get the major branches. They are left gastric, splenic, and common hepatic. Left gastric, splenic, and common hepatic. At least we have to identify. Common hepatic again divides into hepatic artery proper and gastroduodenal. And gastroduodenal again divides into superior pancreatic duodenal and right gastroepiploic artery. Okay. And splenic is passing behind the stomach, which forms the bed of the stomach, one of the member of the bed of the stomach, and ultimately it's a tortuous, and ultimately it supplies the spleen. At the hilum of the spleen, it divides into 4 to 5 segmental branches. Left gastric joins with the right gastric, and it forms arterial anastomosis along the lesser curvature. Right gastric is coming from that is the common hepatic or hepatic artery proper, it can come out. So right gastric and left gastric along the lesser curvature. So along the greater curvature, there is right gastroepiploic, left gastroepiploic. Left gastroepiploic is coming from the splenic artery. Okay. Now about the superior mesenteric artery, we can get the middle colic, which divides into 2 divisions, on right, one on the left side. Middle colic, then right colic, and the superior mesenteric artery is continued as iliocolic artery, which supplies the terminal part of the ilium and the colon. Colon means large gut. Okay. So from the iliocolic artery also we can get appendicular branch. Appendicular artery we can get the cecal artery, so and so. And also it supplies the adjacent area of the colon. Right colic divides into ascending and descending branch. So all these arteries at the periphery, they forms a arterial arcade. Arterial arcade of Drummond. Okay. The marginal artery of the Drummond. Okay. On the lower part, that is the artery of the hindgut, that is the inferior epigastric artery. Inferior, sorry. inferior mesenteric artery, which again divides into left colic branches, which has got ascending and descending. Ascending joins with the left branch of the middle colic. Okay. The segmental supply, that is we know the transverse colon, right 2/3 and left 1/3. This is the junction of midgut and the hindgut. So on this side, this is being supplied by the superior mesenteric, that is the branch of the middle colic, and from here, that is the inferior mesenteric artery, that is the left colic artery branch, the ascending and descending branch, and so left colic and sigmoidal branches, and the superior mesenteric artery itself is constituted as superior rectal artery, which divides into right and left branches and supplies, and from there we can get the azygous arteries, which supplies the rectum and anal canal. Except below the pectinate line, because up to the pectinate line, that is the part of the endodermal gut, and below the pectinate line, that is the ectodermal gut, that is from the skin, proctoderm, that it is developed from the spleen. So that is developed from the proctoderm, that is the ectoderm. Okay. So that is the supply is from the that is the somatic artery, that is the internal pudendal artery, we know. Internal pudendal artery, we know, that is coming out from that is the internal iliac artery. Internal pudendal artery, from there we can get the inferior rectal artery. Okay. So pectinate line is very important, which is called the watershed line. Above it is supplied by superior rectal. Okay. Below inferior rectal and middle rectal is also supplying. So this is the level. So this is the area of separation. Now about the internal iliac, external iliac, we know. Common iliac divides into external iliac and internal iliac at the sacroiliac joint, in front of which we can get the ureter. From the internal iliac, anterior division and posterior division. From the posterior division, we get only 3 arteries: iliolumbar, lateral sacral, and superior gluteal. And all the arteries at the pelvis are supplied from the anterior division. That means superior vesicle, just think of the urinary bladder. Superior vesicle, inferior vesicle. Then the actually superior vesicle, the proximal part is the superior vesicle. The distal part is obliterated umbilical artery. Superior vesicle, inferior vesicle, then obturator artery, they are all coming from the anterior division. Then middle rectal, internal pudendal. In case of female, that is we have seen, that is the uterine artery, and it crosses the ureter. We have seen it crosses the ureter from lateral to medial, where half 1 inch away from the cervico-vaginal junction of the uterus. Okay. So we know that is the water is below the bridge. So that is the uterine artery and internal pudendal artery. Internal pudendal artery we can also find in the back. PIN, pin structure in the gluteal region. We are getting superior and inferior gluteal artery. Superior is from the posterior division. The inferior gluteal artery, it is from the anterior division. So all other arteries except Iliolumbar, lateral sacral and superior gluteal, they are coming out from the posterior division. Okay. So these are the structures we can encounter in the dissection. So now we have to identify.